Thanks for being here. Thanks to our exhibitors, Bristol Myers Squibb and Knickska Pharmaceuticals. Hope I said that right. So my pleasure this morning to introduce our two senior fellows. Hopefully the last of our two fellows in a class. Will be hopefully getting three every year. But they've been great fellows, serving as the chief fellows. I should mention that they were both members of our Jeopardy team last year that won the state competition and advanced to nationals. And they are repeat um, champions again this year. So they'll be representing us at ACC again. Both have passed the Echo boards. So Mike Downey, native of Hopkins, ran track at Hopkins High School, which is a good track team, and then went on to Middlebury, where he was a decathlete. Um, he came back, did med school at the university, and then was a internal medicine and pediatric resident, where he was AOA and won the Gold Humanism Honor Society. He's published extensively, really, on heart failure, arrhythmias, and diversity issues. He's served as a reviewer for multiple journals. He's dedicated mentor, clinician, embodies a commitment to advancing cardiovascular medicine through education, compassionate care and service, reflected in volunteer work, marathon running, and mentorship. We hope that he will be our inaugural EP fellow starting in June. We should find out officially in the next few weeks, I think. So then I'll just introduce Jimmy, and then I'll let them speak. Jimmy is a native of North Dakota, ran track at North Dakota. He was a hurdler, did work in astrophysics, and studied the physics of hurdling there before going on to medical school at North Dakota, and then did residency at Wisconsin. He leads the fellow education this year. His interest in education dates back to med school, where he led a simulation. He's interested in how medical knowledge is organized and delivered, as well as how psychologic predispositions can be leveraged in the context of learning to improve practical outcomes. He will be staying with us here in the Twin Cities as part of the Metro Heart group. So thanks for. Thank you.
Wow. Start a timer here to keep me honest and respect Jimmy's time. And thank you, Dr. Harris. And thank you all for being here today and for the folks online. We get started. Before we get started today, the danger of giving the fellow the podium, just want to say recent global events and certainly things, there's been a lot more sadness and anger in the world recently, and some things get reported and some things don't. But it's, I'm very grateful to be in a field where we get to care for people, and just if we can all help one person a day, that be our contribution. So just something to just acknowledge and think about. All right, so getting started. This talk is a little atypical, and I'm kind of the setup or the appetizer, if you will, and Dr. Evers will be the main course. But I'm hoping to talk a little bit about memory, kind of the state of medical education, and a little bit of kind of metacognition, or meandering down the rabbit hole of thinking about thinking. So some disclosures, no financial disclosures, no off-label medication or device, and any cardiovascular topics discussed are actually tangential. The main cognitive takeaway of this presentation. So we are taking a bit of a swing. The thinking behind this, again, is while in our third year, are certainly by no means experts, and wanted to bring something to the table that was a little bit unique and could hopefully have some takeaways for everybody. CME goals, just have them revisit the idea of doctor as teacher, think about thinking, and I tend to prescribe to this, and probably why I'm overly verbose is I think questions are more important than answers. So hopefully this talk provokes more questions in you than it does answers. So as a quick preamble in thinking about thinking, you've probably heard knowledge is power. That's a common quote. I want to challenge that a little bit. One quote I think is important. I know nothing. I know that I know nothing. And then this is a longer version of that same quote. And of course, because this is a medical talk, we have to reference Socrates in some way. But the longer quote is basically saying that between two people, the one who realizes that they know little is actually better off than the person that thinks that they know a lot. Perhaps stated in more succinct and digestible ways, as our circle of knowledge grows, so does the circumference of darkness surrounding it. So when we think about education and thinking about as we teach more, you can generate more questions. That was Albert Einstein. And then I was born not knowing, and I've only had a little time to change that here and there. Richard Feynman, both prominent scientists and actually very interesting. I won't say, I mean, they're not, yeah, I'll leave them as formal scientists, but some really interesting works if you have time. So getting into the idea of as our circle of knowledge grows, so does this circumference of darkness around it. If we think of a base knowledge base as a sphere, and because I'm a nerd, if that sphere has a given radius, you can calculate the area, right? The sphere represents your summation of knowledge, and then this black extra circle represents everything that you don't know. As you learn more, let's say twice as much, the radius gets twice as big, you know a lot more by surface area, right? But at the same time, what you don't know also grows, or your appreciation of what you don't know. And if you do a little bit of math, that's about a 400% more unknown. Have you really lost knowledge? We just said you learned more. Or are you just better at recognizing the unknown? And so to put it more in concrete terms, if you don't know the aortic valve exists, you don't know to ask about aortic stenosis. If you don't know about aortic stenosis, you can't ask about the severity of aortic stenosis. You can't ask about what causes it. And so as you build knowledge, you recognize even more questions to ask. So questions give you answers, which only gives you more questions. So questions really beget questions. All right. Now let's actually get into medical education and specifically focusing on memory. I gave that preamble just so you could get a sense of maybe a window into my mind and how I think about things, and this may be a little esoteric or meta talk, if you will. So when we think about medical education, just as a super wide overview, and for some of you this will be very proximal, for some of you this is maybe a little more distal, you usually start in the US, again, with some sort of undergraduate degree. This then advances to some post-bac or gap years for folks that don't go straight to medical school, compared to those who go directly to medical school, which is 4 years. And currently the predominant model is a 2+2, 2 years of didactic learning, and then 2 years of rotations. There's also medical licensing exams during that time, the steps if you're MD, the complex exams if you're DO. Then there's internship and residency, and then there's subfellowship. Again, why do I bring this up? Well, the general public undergraduate general education is college. Medical school is considered graduate general education. However, in the medical education world, actually graduate medical education is when you're in internship and residency. Undergraduate medical education refers to medical school. So you graduate from undergrad only to re-enter undergrad when you start medical school. The other thing I think that's important to bring up in this slide is that, again, graduate medical education is very much an apprenticeship model, and that has been kind of the foundation of medical practice since early on. And the last point is the time cost to training a physician, which will come up, but at the bare minimum, you're talking 7 years. For different specialties, 10, for different subspecialties or MD, PhD paths, up to 14 years. So there's a large time lag when we're thinking about training physicians and getting them into the pipeline of actual practice. So changes in medical education take a large time to manifest, in part due to this training pathway. So why talk about undergraduate medical education now? Well, med students become residents, become fellows, become partners, and so that is perhaps one selfish reason you might be interested. There's also been some significant rapid changes both on national and local levels in the way medical education is being taught more recently. And again, given the duration of medical training, especially those of us in cardiology and further advanced subspecialties, those changes we've yet to see trainees who have grown up under those changes, but they are coming. So I think, and the other reason why to talk about undergraduate medical education, well, just if you're going to call ourselves doctors, the origin of the word actually comes from teach or to teach. So I think it's an important part of our job that we're all aware of, but it's quite literally a part of what we call ourselves. So getting into the current state of medical education, there's a big push to move to competency-focused learning models. What those are students advance not based on, okay, you're a first year, you're a second year, you're a third year, fourth year, you're done, but you advance once you've demonstrated some mastery of the skill. This, in a way, is trying to bring the apprenticeship model in earlier. So once you demonstrate that you have mastered renal physiology, you don't need 3 months of renal physiology. You can move on after 1 month. Theoretically, then, this reduces inter-student competition because you're competing against yourself. Once you demonstrate mastery, you've demonstrated mastery, and you move on. It doesn't matter what your co-students are doing, and you all move on at different rates. It increases the efficiency of training. You don't need to sit in a class once you've achieved it. And it also ensures competence because you don't advance if you haven't mastered. So it changes it from a standard 1, 2, 3, 4-year model to a more flexible model. And again, for those that master quicker than the standard timeline, hopefully this would shorten the medical training. Now, there's a lot of issues with implementation and med school cost and all sorts of other things and timelines of match and everything else that make this a little bit more challenging, but that is where the push has been. There's another big one to talk about, which we'll touch on here, but so there's been a big national change in that the licensing exam, step 1, which is the first licensing exam, transitioned to solely pass-fail in 2022. Assuming that all of these students take the shortest timeline to becoming cardiology fellows, they would enter cardiovascular disease fellowship in July of 2027. So there is those fellows will not have had it used to be, for those of you that are unfamiliar, step 1, highly competitive percentile-based exam. People got into residencies or did not get into residencies in large part. That was one of the main filters. If you didn't score above a certain percentile, you could not match into ophthalmology. You could not match into ortho. You could not. So that has changed. How that changes, we'll get into a little bit. Also, on a local, but it's pretty much diffuse across all the medical schools. Almost all medical schools now have gotten away with grades or honors pass-fail and have transitioned purely to a pass-fail model. Class rank is usually not known or available. And remote learning also predominates. And there are repercussions for that from both a psychological standpoint as well as from a networking standpoint, collegial standpoint, hands-on standpoint. But also, again, perhaps more time efficient. You can speed up lectures, the arguments on both sides. So, okay, a lot of changes. I'm trying to be relatively impartial and not insert my editorials of what I think these changes are going to bring. But what do we know about these changes? Again, because of that long lag time, we don't know very much. But what I'm showing you here is the various years of that step 1 licensing examination, the total number of examinees, the overall pass rate, because even though when it was percentile based, there was still a certain percentile that you needed to pass, and then the transition from when it went to pass-fail. So again, 2022 was the first time it went to pass-fail. So this historically represents individuals percentile with a fail line, and this was just the pass-fail format. As you can see, 2021 and back, the lowest was 2017 at an 86% overall pass rate. 2022 and forward, all of a sudden the pass rate dropped. So when we changed how the exam was being assessed, there was a change in just pass rate alone. Now, I can't tell you if people are doing better or not because we're not getting scores on, or that data is not available. But again, just something to think about. There, anecdotally, people are saying students are studying less because they only need to pass. There's not as much pressure. Is that good or is that bad? Some of the knowledge on step one is relatively esoteric and doesn't apply to clinical practice. But again, hard to say. So just remember July 1st, 2027 is, again, if these students were to do, they take this at the end of their second year, if they go to internal medicine in 3 years and then they go right into cardiology, is when they would be matriculating into cardiovascular disease fellowship. Again, not commenting on it good or bad, just to be aware. So when we have a system in flux, and let alone AI, which we'll talk on a little bit, why talk about memory now? Memory and education are obviously very linked. I think it's important that when I say the word memory, there are a lot of things that we attribute to memory that are not part of memory, and what memory actually is and what it actually isn't. So because I am going relatively slow, and I apologize, I will speed up. There's a lot of falsehoods about memory, and so one I want to bring up is the distorted digital mirror. Human memory, when we say the word memory, is not analogous to digital memory. When we say digital memory, you go to your computer, you expect to open up a Word file, you save it, you expect it to be identical the next time, right? Because the computer memory is perfect. Human memory is not retrospective. It was actually evolved to be prospective. So your memory would never evolve to recall the past. It evolved to be an adaptive map for the future. So it doesn't matter how many teeth the bear had that was about to bite you. What matters is the bear was more likely to come at me when I was in this rough approximate scenario, and I remember that rough approximate scenario. So in the future, that's more useful information. So memory was never designed to be total recall. It was designed to be an adaptive tool to help you project in future scenarios what would happen based on past events. It was basically Bayesian probabilities before Bayesian described it. And so I think there's a lot of analogies we make between memory. We say, oh, well, I'm running out of memory, whatever, but human memory and digital memory are not the same thing. And over extrapolation is dangerous because we can get into danger there. Rate of technological change drastically exceeds that of human biologic evolution. This is just a little graphic, right? I mean, our evolutionary rate is basically generational, so roughly our reproductive rate. Technological changes are occurring now at an exponential rate, and our biology is not. So evolution happens with each successive generation. An individual can adapt, but an individual cannot evolve. Technology is evolving at a much more rapid rate. And how that'll interplay with our brains, who knows? This is a super quick aside, which I will kind of skip over, but if there is a population limit for K and R selective species types, we are a K selective species type, meaning we reproduce slowly. The point of this being we're limited by the carrying capacity of our system, which is the energy we can generate. And if we start using more AI, which costs more energy, the only reason we can support 9 billion people on this planet is because we can right now artificially inflate the amount of energy we're using. If we all of a sudden become dependent in AI and that starts to suck up a lot of energy, what will happen to our carrying capacity of our system? Just something to think about, because calories also equal electricity. Again, I am esoteric, I apologize, but and then when I talk about memory, multiple changes to medical education with a long lag time, again, just thinking about that change. And then also, right, I mean, this applies to us on a daily basis, right? If you want to, we are using memory differently than it was when it initially evolved. We use it to recall facts and details, and if we can enhance our memory, could that be useful for us in a daily practice? All right, so is it a failure of memory if when checking someone's labs you get a stat page, and then after you address that page, someone turns around and says, hey, what was the potassium level, and you can't remember it? Just something to think about. Did your memory fail you there? Another one, if you read about a new treatment for pulmonary hypertension 1 year ago and never prescribed it or used it, and then are asked the name of it 1 year later, and you can't recall it, is that memory failure? Can you remember the exact number of red cars you saw onto your commute this morning? I mean, right? That we use that word remember. I, I would guess no one in this room can, but I would postulate to you that there is nothing wrong with your memory. So again, memory is total recall? No. When it comes to making a memory, so there's an initial attention and encoding that needs to happen. Again, we filter out most of what's happening. Only what we focus on gets encoded, and that's kind of that red car example. You know your way to the hospital. The red cars aren't super important for you getting to work, so it doesn't actually end up getting encoded. Most of that then, the sensory inputs go through the thalamus into the hippocampus where your working memory is before it can get stored into long-term storage. The encoding types or depth of processing is basically the memory trace. The more things you can link something to, the more robust the memory. So if you instead of try to memorize a single fact, if you try to relate it to other facts, you build a neural network that makes it more durable. When it comes to that, there's this Atkinson-Shiffman three-stage model of memory, which essentially is that this is that in a picture format. You have sensory memory, which is just what's hitting your senses, super short, either visual or auditory. It's basically reflexes, rapid playback. What you choose to attune to, whether it be my voice or the hot coffee that you're drinking or the fact that your socks are a little crumpled in your foot, that's where your working memory goes. And that's where either things can get then further deeper encoded if you then focus on them while they're in working memory. That takes cognitive effort, and you're limited by your cognitive load. And then it gets stored in long-term memory in different parts of the cortex, or it can get lost. You usually think of people often reference phone numbers having 7 digits. You can usually store about 7 things. In reality, new studies suggest it's closer to about 5 things. The reason phone numbers are 7 digits and we can remember them is because we break them up into 3 chunks. And so you're actually just remembering 3 numbers instead of 7. But there's some flexibility in the amount of working memory you have, and the more cognitive stress you're put under, the less working memory capacity you have. Again, because that's you actively thinking. So if you're actively thinking and you get a page, that interferes with your working memory, and that's why that potassium value that you looked at in the morning while you got a page and then got distracted doesn't actually get encoded to your memory when someone asks about it later. So again, is that a failure of memory, or is it never got stored as a memory in the first place? Factors getting into enhancing that long-term memory, I'll leave that for loading pending Dr. Evers. But factors distracting from memory retention, right? I mean, you can imagine you just make lesions at any part of this pathway and you'll impair memory, right? So lack of attention, you're not even going to get it in short-term memory. So again, that's not paying attention to red cars. It's not even going to hit your short-term memory. Lack of processing, that can be cognitive overload. That can be you just not paying attention to it. It's not going to get into your long-term memory. Once it gets into long-term memory, it does say unlimited capacity on there. That's not quite true. There can be decay. Memories fade over time, especially without robust. The memory is truly lost. There can be issues with actually just retrieving the memory, right? And that's sometimes people have the tip of the tongue phenomenon, right? You know someone's name, you know some fact, you're in a certain situation, you can't recall it, and then you wake up at 2 a.m. and it's like, oh yeah, of course the word was hypotenuse or whatever it happens to be. A large part of that happens because, again, cognitive load, if you're stressed, if you're distracted, if there are other factors eating up your cognitive bandwidth, you then don't have the ability to go to your long-term memory and retrieve it because you can only hold so many things in your working memory. And there's lack of cues. The other important thing, and I will to bring up is, again, when you access long-term memory, it's no longer a long-term memory. You're bringing it into your short-term working memory. And this is where it gets at memory as adaptive, because as soon as you bring it into your working memory, it's modifiable again, which is something that you want, right? If the aorta guidelines change, you want to be able to update your memory of what the aorta guidelines are. If the factors that lead to a bear attack change, you want to be able to update your memory on, oh, well, in addition to bears coming at night when we have a fire and food, they also come in the morning when we leave our food out. And then that memory changes and it gets updated. But that also means that the memory that you have when you were 5, if you think about it and talk about it with your siblings, can be altered based on inputs and things that they add. And so every time you pull up a memory, it changes slightly before you restore it. And I will pause here because this is simply just going through that in a visual way. Long and winding road, again, big memory is not total recall. It's highly modifiable. The more you can pair memories with different memories, make neural networks, the more durable encoding and the easier it is to retrieve. The point of this is memory is modifiable. It is not something that was designed to recall facts. It was designed something to help you predict future events based on past events. So I challenge you to think about memory that way, as opposed to something that's purely a static recall. Things that compete for your attention will compete for your ability to remember things. And technology will continue to advance and change this. All right, and I will pause there.
Thanks everyone for being here. I hugely appreciate the opportunity to speak in front of all of you. This talk hopefully will generate 0 questions, that's a lie, but a little bit more answers and be hopefully more practical. There's 2 goals. One is no fellow left behind, meaning how can we bring up those who struggle to a lower baseline when they're providers? And the second thing is, how can we take people who are doing well and help them exceed faster? Okay, so that's the goal of both of these things. I'll do a little AI caveat, and then we'll get into the meat of the talk, which is this outline. So we'll get into the nature of the problem with medical education, and I think what most trainees and medical students are going to understand very intuitively over the last maybe 10 to 15 years. We're going to talk a little bit about how practically to learn and remember, and then we're going to get into no fellow left behind and how to become an asset. Whenever you criticize anything, it can be interpreted as complaining. That is not what I'm here to do. I am incredibly grateful to everyone at the med school in North Dakota, the providers in University of Wisconsin, and here at MHI in Hennepin, and the patients as well for giving me the opportunity to learn. I'm in 25th grade. And so I am, imagine the left side of this screen is a kindergarten kid. The black box is 25 years of training, and the right side is a cardiologist. And what exactly goes into that black box is kind of what, the big picture of what we're trying to sort out. And here's a short list of those things. The only thing we'll focus on today is the left side of this screen, which is knowledge, and none of the soft skills. I don't want you to interpret soft skills as derogatory or lesser importance, but that's just for ease of deciding. So knowledge is the summation of all the pieces of information, the learned pattern recognition, and the experience, and anecdotal or not, that you've had that helps you when it's practical. And when it's practical is when it gets to the patient. So that's what we're really here to serve. The obligatory AI comment these days, true or false? As the price of knowledge gets cheaper, the value proposition of a provider will slowly shift towards soft skills and away from content expertise. It's a really hard question, I think. I will argue for false. So Google search launched September 4th, 1998. Do you feel in your life that decision-making has become more straightforward or more challenging since that happened? Would you be more or less likely to pay for consulting service or advice, like a financial advisor, an accountant, a realtor, a business consultant? If unfortunately you or your family member had cancer, would you be more or less likely to seek out an oncologist who has experience with that problem? I think when it gets to healthcare, we all recognize the importance of content expertise and these items here. So in my opinion, when information is more ubiquitous, why seek advisement? These are typically the reasons. The first reason is you don't know what you don't know, which Mike touched on, that huge black circumferential circle of things you don't know. And not just that everyone doesn't know, but that you specifically don't know. So you fear that you're missing out on something. Right? I want to go to an accountant because maybe they know some tax thing that I could save $20,000 this year, for example. And I just wouldn't know that. Maybe I want it just for convenience itself. I want a financial advisor. I don't want to have to think about it. I just want to, they take my money and they do well for me. Sounds good. So convenience is a big part of this. I think from a physician perspective, one of our primary roles is number 2, which is contextualization. Is this information relevant to me, urgent to me, important to me? How does all of medical knowledge apply to me in this particular time and place? And I think that is often the questions we are all asking, particularly in cardiology. And so in summary, as total knowledge goes up and knowledge becomes ubiquitous, what actually happens is our expectations go up. And we have more questions to ask. So again, forgetting all those soft skills, focusing on knowledge, how do we actually get better? Here's the nature of the problem that all of our trainees are going to understand. In 2011, they came out with a study modeling medical knowledge. This is the sum total of medical knowledge, basically describing this fear that Mike described before. In 1950, the doubling time was 50 years. 1980, the doubling time was 7 years. And when I graduated in 2020, the summation of all medical knowledge doubled every 73 days. Students who graduate in 2020 will experience 4 doublings in medical knowledge by the time they complete the minimum length of training, 7 years. It's been 10 years since then. So what was learned in the first 3 years of medical school will be just 6% of what is known at the end of the decade, from 2010 to 2020. And I think this is the real struggle that medical students and trainees are having a really hard time coming up with. The thing to differentiate there is this is sort of a model of all knowledge. Of course, everyone's not going to have to know all knowledge. This is sort of a relevance-adjusted way to look at this. So this is the Bible for the Step 1 exam that Mike talked about, which is the actual go-to text for basically what you have to have memorized before you sit for your medical boards. And that's the chart that we're attempting to keep up with. And here is getting into a little bit about thinking and remembering. Here's what we're up against. This is sort of the enemy as I speak. This was a study done in the 1800s by Dr. Ebbinghaus in Germany. This is a psychology study alone, getting at the true mechanics of just rote memory. So no context, no nothing. He actually had 3-letter syllables that he had himself only. So this is a 1-person study. Try to memorize. There's like 15 3-letter syllables, essentially, and they had no connection to one another. So there's no context. And how much do you remember? And in a week, he knew 10% of the list. And so, if I ask you right now, when was Google search started? Some of you are going to remember that from 3 slides ago. If I texted you again tonight and asked you, less of you are going to know. But if I actually did that, and then I told you the answer, you would start to encode that into long-term memory. So that's the rate at which you'll forget that information, and maybe something we can do to combat this curve. Basically, there's 2 different sides to this coin. One is getting the information in, putting it in a place in your brain where it'll stick, and second is driving back and forth on that neural pathway to get that information and retrieve it in a context-appropriate way, and to do that repeatedly. The important things with encoding information are the context. We'll go through these specifically. Context, relevance, and difficulty. But the next important feature of combating the forgetting curve is that you have to actively recall it. So if I just tell you again that Google search came out in September of 1998, you'll be like, sounds good again. Your brain won't really work with that information and we'll move on. It won't really help you remember. The actual act of really trying to remember when it happened is where you learn. So active retrieval is important. Spaced repetition is also something we're going to basically talk the rest of the time about, so we'll talk about that later. And then information overload is counterproductive. My wife and I bought a new house. There it is. I think none of you probably have any idea where it is, although it's on the screen, because it's totally outside of the context that you're used to. If I put it here, everyone kind of has a general idea for where we bought the house, right? And that's because there's several other points of contact on this map that your brain's already familiar with. So this fits into a schema that makes sense to you. Relevance. We had a great talk back in March from Saeed Al-Sadawi about aortic stenosis, severity, and atrial fibrillation, which is a real problem. we're all sort of used to averaging out X number of beats and leaving that as our aortic valve area. This talk was so good to all of us who read echo because it was right at that point of challenge, that point of relevance, that point where we might differentiate it from what we've typically been told to do in guidelines. It's right at that tipping point. Those of us who don't read echo, I'm sure we're sort of like, whatever. You know, I'm not going to remember this information. Why would I? But for echo readers, I think, you could just see everyone in the crowd drooling over how awesome this piece of information was. Also, it really has to meet you where you're at as far as difficulty. So I remember as a first year, Dr. Samara gave our first talk on hypoplastic left heart syndrome. And I had one takeaway, which was that I needed to learn more about hypoplastic left heart syndrome. And that's because I just didn't have the context to really fit anything that he said into any other prior schema. And so given this, the rapid exponential rise of medical knowledge, the linear-ish rise in relevant medical knowledge, medical students started to get desperate for ways to operationalize and leverage all what we've talked about in order to learn more. And here's what they came up with. A man in Australia created a software to learn Japanese, and that was called Anki or Anki. And this is essentially blown up in medical training, and almost everybody uses this to help to remember things. So it's an advanced flashcard software service. No more index cards, it's all on a computer. And what this does is it automates spaced repetition, so it gives you the flashcard at appropriate intervals of time, depending on how confident you were in the question or whether you got it right or wrong. And so that is very helpful for meeting you where you're at and incorporating spaced repetition. I would argue that creating your own flashcards is helpful. You can do that on this software because it helps you to encode it better, and you have to work through your working memory. Just, as you guys, when you write things down, you remember it better than maybe when you listen to it on a podcast while you're running or something like that. And basically, medical students become a machine for about 3 months, and they churn through 30,000 flashcards that they have to know. Approaching the test, they're doing about 1,000 a day. They're doing 80 board-style questions and about 1,000 flashcards a day. So they're basically doing everything they can to become mechanized because there is so much information that they have to be able to retrieve on test day. Anki has really, really good evidence. The CBSE exam was developed by medical schools so that students could take the exam and have a sense of whether or not they would pass step one. So it's essentially like, how do we get our med students not to fail? Is we give them this test beforehand and see if they pass, and only let them take the test if they've already passed this one. And so the CBSE is basically a mock step one exam, and people who used Anki did 13% better on that test than those who didn't. That was also true to a lesser extent on other course exams. This was regardless of their MCAT scores. So they actually did try to quantify essentially for IQ. A lot of these aptitude tests, such as the ACT, SAT, MCATs, are essentially surrogates for IQ tests. This test is an achievement test, not an aptitude test. And so it doesn't correlate super well with just IQ and cognition alone. So here are the learning takeaways. When you learn something, you must learn in the right context, in the right relevance, and the right difficulty for you personally, which is why learning can be such a personal experience. It has to go from broad to narrow. When I studied for echo boards, I read a large conceptual textbook first. The second thing I did is put very specific data points into that contextual framework, and then I did practice questions. You learn the concepts, you learn the specifics, and then you apply those repeatedly. That's how you do that. Unfortunately, what we're trying to do is not a test. We're trying to take care of patients. That's our test, is to do really well in taking care of patients. And this is not something that you can get really good at for 3 months and then sort of do a really good job and then sort of just let it peter out over the course of your cardiology career, right? This is the lifelong learning term. And so actually the best thing you can do for that is enjoy what you're learning. That's really, it's the only way to really combat this. So we're trying to play a little bit of tricks. For example, the app Duolingo essentially tries to gamify learning a language, gamify playing chess. There's actually a math learning thing on Duolingo now. They're trying to expand beyond learning languages. But what it does is essentially it gives you little dopamine hits of good job and, we'll see you tomorrow. And then on your phone, the app will actually start to frown when you haven't opened the app in a while. The widget will start to sort of bug you. And so it's trying to encourage you in many ways to sort of come back. So no fellow left behind. This is going to be sort of broadly applied to internal medicine residency, just so we don't only talk about specifics of our program. But as you know, the first 4 years of med school, the first 2 years essentially you don't have anything to do other than learn. You go to lectures and you learn a bunch of stuff. The third and fourth year you do have clerkships, but it's not as time intensive, I would say. And so we have an extremely structured content. This week we're doing the cardiovascular system and we're doing pathophysiology, et cetera, pharmacology, X, Y, and Z. When you get into third and fourth year of med school, you start to get clerkship based. So this is more oriented towards what a job might look like. So like OB or peds or surgery, something like that. And then obviously residency and fellowship are going to be specific to whatever you're doing. But this huge red line in the middle here is, I think, when assisted structured learning essentially stops. So you have an extreme amount of structured content throughout medical school, an expectation of what you're going to be reading, what you're trying to learn, and what tests you're going to be taking. I would argue that once you get into residency, it's up to you. You basically, to some degree, are on your own to figure out what it is that you should be learning. And the only thing that really guides you as far as what you should be learning is you have a test to take. And so people have basically sold programs to tell you how to do well in this test. And so a huge problem in medical education these days and in the future is this thing we call imposter syndrome. And that is because we don't know what expectations are exactly. For example, I very often feel, gosh, do I know enough? Am I good enough at this to take care of patients? Am I as competent as my colleagues? And so I ask myself this question, am I good enough? And I think that's a good question to ask. And what I'll say is, amongst trainees, even if you are at the absolute top echelon in every way that we're measured, you still feel an unbelievable amount of this imposter syndrome throughout your workday. And that's because the amount that you can know is so huge and so unknowable that even if you're at the 99th percentile, there's a huge gap between you and someone who's been doing this for 5 years. And so what I'd like to do, ideally, is come up with a way that we can have a system of structured learning that's built so that everyone has a general idea of the expectations on them. What should I know at this phase? Has anyone really thought through what I should know at this phase? And actually offer that. And I can tell you that trainees are begging for more material, more support, and more encouragement on what exactly it is that they should be learning and should know at their stage in training. And they remain enthusiastic when they don't feel overwhelmed. And so the top of this is basically my internal medicine schedule when I was at Wisconsin. It is simply a list of different rotations that I'm on. It's nothing special. But what our lectures looked like is 3 days a week. We would have lectures at lunch, and there was no time off for that. So if you were busy, you didn't go, and if you weren't busy, you went, and that was it. And so you can imagine every single resident is getting a totally different experience. They're getting a totally different number of lectures. They're totally unstructured, and there's no repetition built into that system whatsoever. And that's, a huge problem. What I'm advocating for is this thing underneath all of that, which is this structure to fill this space. Here's where it matters for staff. For example, in a medicine residency, you would have designated teaching leaders in different departments, and they would essentially create and modify these knowledge bits, we'll call them, which are just flashcards. that are going to be incorporated in this way. So when you start your intern year of medicine, Dr. Sharkey has to decide, here's the 50 flashcards that every intern will know offhand when they're done with intern year. And if they don't, they turn around and they go back. Something like that. And I think the hard part of that is who makes the flashcards and what exactly questions do you ask. That is really requires a lot of work. But anyway, you could have 6 of these throughout the first half of your year, and then if you have an aspiring cardiologist, the end of their second year and third year, you could have a lot more basically decks in that regard. So that's how we're going to bring the bottom up. Now, to become an asset within your group, I would advocate that this is a really good way to build confidence in a new area of expertise and have a lot more information offhand. We see very often, multiple cardiologists in the echo lab will say, hey, what do you think of this problem that I saw the other day? And this is a way that you can sort of be the asset of the group. And I really do know everything about prevention in my career because I have built 500 flashcards that I forced myself to do that nobody else is doing, right? And so it becomes this creative endeavor because it's such an infinite world of knowledge that you really have to pick this individual slice that you want to be the expert at. And so I think this is really kind of fun and exciting, and you can get creative with what exactly you want to know. For an example, for me, I find a lot of value in knowing exactly the absolute number needed to treat in order to help somebody. And so I can go with the patient to that information relatively offhand. You can say, well, should I really take a statin? What's the benefit? And I can say, this is the benefit for you offhand. That's a complex question, but that's the type of information that I want to know. So in summary, knowledge is becoming ubiquitous. This is a paradox. I think the more knowledge we have, the more our expectations rise, and it's not necessarily easier to make complex decisions. We have incredible tools already that exist for encoding and retaining this knowledge, and I think if we operationalize them post-medical school, we would have a lot more confident providers with less imposter syndrome and would allow us to basically raise the level of what it means to be a provider, as well as decide on your own what type of asset you want to be for your group. Going from this resident to this resident. That's all I got. Questions, thoughts, concerns?
I got a question.
Yeah.
Great talks, both of you.
Thank you.
So fascinating to learn about memory and storage and educational process. I'm looking at Dr. Sharkey. And we all know people that can quote number needed to treat and all the studies going back for 40 years and the latest, greatest. But the greatest clinicians that we tend to go to have this acumen that's a consolidation of these memories and gestalt of the patient and their values. Where does that come into memory in your brain? How did he develop that? Different than others. And what's the learning process for that?
Totally agree. So in the beginning, when I defined knowledge, bits of information was one of the pieces, and 2 of the 3 pieces were anecdotal experience and pattern recognition, which I think is, those 2 things kind of fit the flavor of what you're saying a little bit better. Pattern recognition and anecdotal experience. The best thing we've done in medical training that I've heard from my staff all throughout the way is that the fundamental point of learning is at the bedside and with the patient. So none of this can replace seeing patients. And the reason for that, so experience is the answer to your question. But the thing about having a patient be your teacher is that it takes all of the things that I described that are important for learning, which is the context, the relevance, the challenge. You get common things commonly, so it repeats when it's important. And then you can't hem and haw about knowledge you don't know. You have to give the patient advice, They have to have a deliverable, essentially, on whatever it is that they're asking. So I think the answer to your question is years of experience.
It's still pretty variable though, isn't it? We all know that, right? 40 years of experience in one person isn't the same
Oh,
as
sure.
Dr. Sharkey. So that's what I'm saying.
I agree.
How do we get to those levels? Well, come on, it's not assumed, it's acknowledged by us all that
I
there's
agree.
different degrees of acumen, regardless of experience.
Enthusiasm would be my answer to that, because it's maintainable.
And I would add to that, it's the shorthand of that is it's not just reps, but it's reps with intention. And given we have a fixed amount of working memory, if you walk into a patient's room and you have a good differential diagnosis and all these other things ready, available for you, then you are more attuned to, oh, they're a little sweaty, they're a little fidgety, I'm gonna help calm them down. And so you can use that cognitive effort and pick up on those things, and you develop that acumen faster. And so it's basically an exponential curve. And the sooner you can start on the inflection of the curve, you don't need the 40 years, you only maybe need the 10 years.
Yeah, but I think fundamentally, to be a lifelong learner, you have to enjoy it, because otherwise, at some point, you're going to stop, right? You're just going to be like, oh, I went to clinic, I saw my people, I wrote the note, I did the bare minimum acceptable, socially acceptable in my group, like X, Y, and Z thing, and then I sort of went home for the day. That's, there's that. And so if you don't really have enthusiasm about what it is that you're doing and offering, that you're not going to be accessing your working memory as often as possible, and you're not going to just incrementally improve every time. So I think enthusiasm is the answer to that.
I compliment both of you for taking a swing and making a hit. Thank you for making us think. One thing that I've noticed in my career regarding knowledge or information, which are two different things, right, is that knowledge isn't fixed. And what we knew 20 years ago changes. And one of the hardest things that I've found is realizing when knowledge is wrong or information is wrong and it changes because medicine's treatment has changed. So I just wonder how you would approach that kind of ongoing learning as we get into our 70s, 80s, that it's not a fixed, okay, I'm a resident, I'm a fellow. It's how do you continue that process once you're beyond that stage?
So one possible answer to what you're saying is I can actually type in right now on Gemini or ChatGPT and say, can you summarize the ACC bulk guidelines for 2020? And then I could keep a depository of those flashcards there. When a new guideline comes out, I can say, can you iterate on these to incorporate the new guideline? And so there is actually ways now that we can basically have these cards made for us if we wanted to, and that they could be dynamic and self-iterative when new guidelines come out. I don't think it would be the right thing to do when one new study comes out, for example. I think at the education level for trainees, guideline is probably the right level of, the tip of the spear for knowledge. But, let's say you're the expert in the group on reading PET for sarcoid, you could take individual studies and sort of incorporate those into what you know. And so that's, I guess, one way to be dynamic about it. And actually, there are ways to automate that, where you don't have to personally go in and change everything every time, where it iterates on itself.
And also I'll add to the idea of having really well-developed neural networks after something being known for 20 years and then a change, going back and doing a cognitive autopsy instead of just saying, oh, I need to forget what I thought was true and change it. Go back and identify what is my entire thought process regarding this topic, and instead of trying to delete and replace, how can I restructure that to fit this new piece in to change the understanding? Because you're going to fall back into that automatic pathway that you spent 20 years building. And so rather than wiping it away and trying to rewire a bunch of neuronal synapses, make new connections that continue to flow through it. Unless, I mean, we got something totally backwards and then.
It was a great, thought-provoking talk, guys, so thanks so much for doing that. Have you thought, I'm sure you have, of ways that we could improve our fellow education, for example, at the Wednesday afternoon sessions?
Yes, I thought a lot about that. Had a year to think about that. There's so much to say. I think if you want a deliverable, the answer would be for us to have a structured half day for a staff. So interventional EP groups are currently doing this for us, where somebody has a half day of admin on Wednesdays, and they're sort of locked in to be the teacher for the day. So for example, when I'm trying to organize what we're going to learn and when in our fellowship, it's very, very challenging to do because I don't know who is going to be, from a schedule, like just from a logistic practical perspective, I don't know who's going to be available that day to basically give us a lecture. And so that obviously takes some buy-in from the group on your guys' end. But it would essentially allow us to say, okay, we're going to get congenital. We're going to get it 3 times a year. We're going to get revascularization 3 times a year. We're going to get all the early stuff. So when our first year fellows come in, we hammer home on heart failure, cardiogenic shock, and STEMI. We hit all those things. We know exactly who's going to give the lecture, and then we can sort of improve on it iteratively over time. But right now, the struggle is definitely that I can't basically do any of that structure because I don't have someone who I know will be there. At Hennepin we do, and here with EP and interventional we do, so I actually think we do a little better job educating on those subspecialty things because there's someone there, and I can make sure it repeats. But that would be the one thing I could think of, like, right off the top of my head.
And then to your spaced repetition point as well, asking presenters or speakers to make a 1-page synopsis slide that then gets showed at the next week. And certainly that could also be, we could do that at Grand Rounds, right? We could ask that and then show the last Grand Rounds 1-page synopsis the next week. And so there is that then built-in reinforcement for those who choose to engage with it.
Great talk, both of you, and I'm really glad the angle that you guys chose to go at because I think it's really relevant to me. So I'm really happy I came. But I have 2 questions, and I'm gonna make you guys think way back to medical school because that's relevant to me as well. So the first question I had was, seeing that chart that you guys showed was really spoke out to me. That graph that showed how much more knowledge these medical students are having to memorize and know in medical school. And I mean, just seeing back from 2005 to 2025 now, I mean, it looked like it almost doubled the amount of knowledge that medical students need to know. So I know you guys both said you weren't going to give your opinions on this, but I'm going to ask you to. Do you think, what's the, not fix for this, but how do you think medical students should attack this problem with the amount of knowledge? I know Anki, and I use Anki, and I'm sure a lot of everyone does as well. But do you think there's a bigger fix? Do you think maybe medical school needs to, stop or maybe not go as advanced into some of these areas because there's you can go down such a rabbit hole in each system? Or do you think this amount of knowledge needs to remain the same, but they need to structure it differently so that we can, have a better way of learning all this large amount of knowledge just in our 4 years of medical school?
That is a hard question. There is an entire national institution trying to sort out this problem, right? So there's a lot of input from a lot of different people. both physicians and sort of PhD biomedical sciences people that are trying to insert exactly what's relevant into your curriculum. They've actually shortened that curriculum to 18 months. So you can see patients earlier in medical school, which I think is probably good. But to get really specifically at your question, so there's the first thought that comes to my head is whenever you put a new piece of information in, you have to take a new piece of information out. Then we have a level amount of what you have to know. The problem is, and you don't know your future career yet. So there's a lot of things that I learned that are relevant to me as a cardiologist. In fact, most of it. But there's quite a bit that, I spent a lot of time looking at histology slides, for example, in my first year and trying to memorize, exactly what a non-caseated granuloma looks like on a slide, right? As opposed to like eosinophilia. I don't use that every day, I would say, in my practice. And so the only way I can really think to do it as this problem continues to happen is maybe to differentiate at a different point. I don't know quite how to structure that. Mike, do you have a better answer than me?
Yeah, sorry for that. And I have another question that's easier.
Oh, what one?
Let's leave for that.
Yeah, we are at time, right? No, I think it's really, I think, and to Jimmy's point about being passionate, I think one of the perils of medical school, the increased knowledge burden, length of training, knowledge overload that is facing trainees is to not lose the forest for the trees, is to make sure that we, as educators, keep the passion for why we're doing this in the first place at the forefront. Because if you're engaged, it's going to be a lot better. So don't drown in the facts and lose the patient. And so whether that's incorporating more patient encounters to have more context to make it easier to hang that knowledge and build those networks. And then as well as, to Jimmy's point, the histology slides, when you think about it from a educational semantic standpoint, the value in memorizing all those things, certainly most people don't become pathologists, but it's a cognitive exercise in attention and repetition and focus. And so if that's the main long-term educational goal out of it, because you're not going to use that specific information, can we transition that to something else that contains information that you will need to know long-term while still keeping that underlying long-term educational goal?
Thank you for those answers. And I will say, part of the reason I asked that just to show to my dad that I have to learn double the knowledge he learned in his medical school. So he can cut me a break on that.
Just do your work.
But okay, so my second question, I hope it's easier, but this is actually going to go back all the way to the first or second slide from you, Dr. Downey. So, I saw that a lot of medical schools you're saying are moving to pass-fail in the step one as well, in especially the grades pass-fail. So I'm a little concerned as how medical students are able to differentiate themselves from one another when it comes to applying to residencies or fellowships. And now I know why you had so much knowledge on this when we did talk. You had mentioned, some residencies and programs are looking all the way back to your MCAT score. So is this actually happening? And how do you, I know you said you weren't going to give an opinion, but do you think this is, good that they're looking all the way back to your MCAT score? Do you think it should remain that we should still have grades in medical school so they can look at more recent scores?
It's a great question. So I will partially answer your question, partially not answer your question. But I think, and certainly, right, anytime you make a change, every reaction has a counter reaction. There has been a big push now, step 2, which used to be basically functionally a pass-fail exam, although you did get a score. Residency programs are now turning to that score, and now we've seen that become much more highly competitive because the residency program directors are going, we don't have a way to differentiate these students. Everyone has great letters of rec, everyone has tons of research, and I have nothing else. And now that we're doing remote interviews, I get 1,000 candidates. How do I filter? I can't read all this. I have to filter on something. And so people are using MCATs, people are using step 2, they're using some sort of metric. Now, there's a lot of problems with using standardized tests, but it's hard to get around that as well. I think the value of grades does come into play a little bit there because it allows for a slightly more local, to help them understand in your local environment, were you thriving or not. So I do think there's a balance there. I think perhaps grades without class rank might be a more useful way to go because at the same time, you don't want people cutting pages out of library books so that their neighbors can't get that same information. So they score higher on the curve, right? And so that's the thing you want to prevent because, I mean, the practice of medicine is collaborative. So why would we want a training environment that's antagonistic? Right? We want it to mirror the practice as much as we can. Half answer for you.
I would just say, I agree with the premise of your question. I have a personal bias that I think, gamifying this whole thing does come with its risks and its challenges, which essentially is become like a game that you want to be good at, which is answering these questions. From a personal perspective, I think coming from a non-physician family in North Dakota and having limited access to research opportunities, my way to get into a good med school is to do well in this test. Or a good residency, excuse me. And similarly for the MCAT. So this was sort of the thing that I could leverage to try to stand out. So the flip side of that argument that I'm making is that people that have access to more socioeconomic status essentially do better on these tests. So that is actually the exact opposite of what I just said, essentially, right? So I kind of interpreted my position from the beginning to be difficult and not having a lot of opportunities, and I saw this thing as like the ultimate meritocracy of how I could get to the top, right? Because I don't have connections, and I don't have a great place to do a lot of research. So it's kind of interesting how it works both ways, I guess. There's a way for me to differentiate myself better, but when you look at the numbers, it does the opposite. So. Yeah.
Okay, so thanks. Thanks, guys. You both great talk. I love the part about the spaced repetition, and we all know how we have been investing in this too much. I have personally used it for 6 years. Incredible tool. The two questions that I have at my stage that I have been recently thinking about is, when would the spaced repetition be too much that it can actually turn against its own purpose? And my second question is, what do you guys think about when you transitioned from each stage to the next stage in terms of what you're gonna keep or what you're gonna dismiss? Because at some point I felt it's turning overwhelming to myself, and I just can't think what should I keep and what should I not keep.
Yeah, another hard question.
Sorry about that.
So when the whole world of this knowledge is so chaotic and so large, it's easy to get lost. But I will say it's also never been easy to differentiate yourself from your peers. For example, I would walk around to my co-residents in medicine residency and say, oh, like, what did you think of this in the guideline? And they were like, what? They hadn't read the guideline. I was like, oh, I thought we had all read the guidelines. I just kind of assumed that in medicine, we all focus on the guidelines. And nobody really had. They just kind of show up to work and their senior resident tells them what to do and when, and they review each patient, and it's safe that way. But I think the way to differentiate yourself is to basically take what's already been provided for you from your societies, et cetera, and read those things well. So at that transition point when you're becoming an intern, that's what I would really focus on, is staying really broad, reading the guidelines for all the different things, and trying not to harpoon yourself too much into one particular area. As far as how many flashcards is too much, I think that's too personal of a question. That's gonna be up to you. For me personally, I could hardly stand doing, I can't even imagine 1,000 a day. I mean, you're just sitting there like as fast as you can, pressing this button and it's going through your head. And it's actually quite amazing watching some of these medical students who rely solely on Anki go through their knowledge base. It's really incredible. But I don't know how to answer how many is too many.
And part of the idea with that spaced repetition is it's dynamic, right? The more you get that certain thing correct or you have that fact, it gets spaced out more and eventually phases out. The other thing I'll add is the more you can build, when people talk about memory, first of all, photographic memory doesn't exist. Highly superior autobiographic memory does, but that's a side point. The idea of like memory palaces or cognitive structures or frameworks, we remember things better when we link them with other things. So as things continue to evolve, as you continue to add flashcards or add facts or add ideas, linking them back to that same process, right? So not just remembering that ceftriaxone is a third class cephalosporin, but if you think about its mechanism of action, and then that's your link to, okay, now I remember how our various beta-lactams and all that stuff works. Every time you activate, ceftriaxone for pneumonia, you also activate the whole network. And so realizing that you don't need to recall every fact of that whole network every single time to reinforce the whole network. And so the more cognizant you can be of building networks as opposed to individual things to try to hold on to, the more robust. And that's why you'll see people say human memory is infinite. I mean, it's not, but the more you can network it, the more you can try to, yeah.
That sounds like it's it.
Yeah.